Welcome to Parallax by Ankur Kalra, a podcast produced by Radcliffe Cardiology to bring you a new angle of all things cardiology and the best from the US Cardiology Review. Published every second Monday, Ankur Kalra, MD, interventional cardiologist at the Cleveland Clinic in Ohio, USA, speaks with legendary cardiologists, reviews late-breaking trials, and interviews authors of our latest and best US Cardiology Review articles. We call them #audio articles. Parallax is the effect whereby the position or direction of an object appears to differ when viewed from different positions. So this podcast is your fix of reliable updates on all things cardiology by someone from a non-traditional background who is always looking at the industry from a new angle. Now, here's your host, Ankur Kalra, MD.
Hello, everyone. This is Ankur, and this is, I believe, episode 28 of Parallax. This is a very special episode for me. I have with me two very special guests today. They're actually not even guests; they're part of what I consider my work family. So, my first guest is Dr. Anmar Kanaa'N. Dr. Kanaa'N is an interventional cardiologist at the Cleveland Clinic, and he is the director of the structural heart program at Cleveland Clinic, Akron General. My second guest is Dr. Joseph Lahorra. Dr. Lahorra is a staff cardiac surgeon at the Cleveland Clinic and chairman of the Heart, Vascular, and Thoracic department at Cleveland Clinic, Akron General. Anmar and Joe, welcome on the show.
Yeah, thank you.
Thanks for having us, Doctor. It's a pleasure to be here.
Yeah, what a pleasure it is.
It's really special for me because I've been wanting to do this with both of you, and I just wanted the timing to be right, for our program to mature, for it to be a year old, for us to have some cases under the belt, which, I can proudly say that we now have achieved and accomplished thanks to both you and Anmar. And I think, our audience, a lot of whom happen to be early career cardiologists or fellows in training who would graduate or are in the process of starting new structural heart programs, with the revised Center for Medicare and Medicaid Services guidelines that came out last year. I think both you and Anmar have really gone through the pains of establishing and starting a new program, a new structural heart program. So I'm going to start with you, Anmar. When you came to Akron General, correct me if I'm wrong, about 4 or 5 years ago, you sort of had that seed in your mind, and you planted that seed out in the universe that, I'm going to come here and start a structural heart program, revamp the place, make it state of the art. So tell us more about that.
So when I first came to Akron General, this was in September of 2015, the pretense was for me to be an interventional cardiologist there first and foremost. But I had emphasized a plan which really emphasized the fact that structural heart disease and specifically transcatheter aortic valve replacement, or TAVR, was here to stay. And I was hoping to catch the early wave of that to get us on board with everything prior to everybody else taking off. And I think that was a part of the reason why I was really onboarded very quickly with the hospital as soon as I talked to them and had the interviews. This plan was already thought about from administration, and they had a need for it, and they were looking forward to getting that started. So as you said, I had planted that seed very early. From the time we planted the seed till the time of fruition, there's a lot that happened along the way, and a lot that we had become mindful of and gone through the motions, which took us to where we are today with a full-blown structural heart program, specifically TAVR for now.
Joe, do you want to add to what Anmar said? Because I think you came to Akron at about the same time, I think from up north at the clinic.
I did. I came down roughly the same time that Anmar did. And, in our discussions, I think that our thoughts about structural heart, but as Anmar says, TAVR in particular, really converged. I think that we both realized that this was going to be, a revolutionary paradigm shift in the treatment of aortic stenosis in particular. And I think that we also realized that for a program of our size and our ambitions in cardiovascular medicine, that if we did not have this skill set, we would not be serving our patient population well, and we would not be able to maintain a staff that was of the highest quality and on the cutting edge. So I think we both had intense interest in this approach to aortic valve disease, but we also realized that in truth, it was really essential to the program, the hospital, and the community.
So thank you for having that vision. My next question to both of you, and a natural follow-up question, is how did you pitch that to the administration locally at Akron? And how did you pitch that to the administration at main campus? Was there a natural buy-in to starting a program in the region? Given that, the main campus had the expertise in structural heart disease and transcatheter aortic valve replacement. Joe, do you want to take that up first?
Sure. In that regard, I have to give a lot of credit to heart and vascular leadership at main campus. I think particularly Dr. Svensson and Dr. Kapadia, because as sort of part of my annual discussions with them about where our practice is going and what we intend to do, I brought up TAVR, particularly when Ankur or Anmar rather onboarded, and they were immediately open-minded to this, and I think it's because they realized how explosive this technology was, how good the outcomes were becoming, and how much need there would be in the community. And I think they agreed that we would have to have this capability in order to serve our community and attract and maintain the staff. So I would have to say that we did not have any struggle with the Cleveland Clinic main campus to convince them that this was essential. We basically said, we would like to do this. We think it's important and necessary. And they said, we agree, and we will help you do it. So we benefited from, I think, their insight right off the bat. That was very important.
And Anmar, as an interventional cardiologist who was coming to start a program at Akron, what were some of the shouldn't really call it pitfalls. I think what were some of the hidden challenges that you encountered, when it came to buy-in or convincing the leadership that this was important, that a program of this nature and this stature and obviously the volumes that we all foresee could happen at a regional center like Akron?
So I think first of all, I want to echo what Joe had said about the adoption of heart and vascular and thoracic at main campus Cleveland, to just the concept or the idea of having another TAVR program nearby at one of the regional hospitals. They really adopted that very, very quickly. And like Joe said, there was really it was not a negotiation. It was not a discussion. It was more, how can we make this happen? I think for me personally, I joined the faculty, and this was my first job out of my fellowship training. So first and foremost, my initial job was to at least prove myself as an interventional cardiologist and do well there, and slowly branch out into more advanced technologies in structural heart disease. And I think that was key to getting that rolling, actually. And once you get some sort of a reputation that outcomes are good, things are going well, then you can slowly keep inching forward with that. I think the most important thing for us locally is the fact that I work with people who are very open-minded about ideas, are very easy to adopt ideas that they perceive are essential for treating our patients. And we just simply said, we just work very, very well together. And I think Dr. Lahorra had been pushing this forward quite heavily from the get-go. And to have him as a part of the team was a huge blessing to us. And on top of that, we had tremendous support from Dr. Svensson, Dr. Kapadia, and now Dr. Reed, Dr. Puri, and Dr. Krishnaswamy from main campus to help us just move forward. And we are now considered an extension of that team. So it starts with just trying to prove yourself as somebody who is serious, dedicated, just try to do a good job day to day and just try to take care of your patients and do what's best for your patients. And I think we all come together when it comes to trying to do what is absolutely best for our patients.
Yes, it's something which is not hard, not really hard to see. It resonated really well when I came to join the team last year at Akron. And what really struck me and still to date is very admirable, for both you and as well as Joe, is how well liked you are by everyone in the hospital. And how even Anmar, I don't think I've told you this before, but when I'm taking call and I'm locally in the area, because I don't live around here, I went to Robex just to grab a smoothie after a workout, and I met someone. I was wearing my Cleveland Clinic Akron General jersey, and that person said, "Hey, do you know Dr. Kanaa'N?" I was like, "Yeah, I work with him. He's my partner. He's my buddy." And he's like, "Yeah, he saved my life. He's a great guy." It's like, wow. It's like even at Robex, people know him. I know people know him within the campus, but this is like at Robex, people know him. So, that resonated really well. Still resonates today really well with me. It's like how well liked you are, both of you, by everyone. And the trust factor, which I think is key for any proceduralist, to have, not only from patients but also from colleagues who refer their patients to us. I think it's extremely important to build that trust relationship with the referring physician as well as with patients. How did you think that you were consciously building a referral base, Joe and Anmar, or was it something that is it something that comes naturally to any practice, or is it something that you have to make concerted effort?
I can start with that, Joe, if you don't mind. What I will say is, for me coming in as the new guy, Joe had a lot of experience prior to coming to Akron General. And again, we have Dr. David Hedrick also, who had joined us, had a lot of experience. For me, I think I was just very lucky that I basically just tagged along and followed what Joe and Dave were doing. They set the tone. I just followed along and things just fell into place. And I think that the key thing is whether you put effort or not, if you're doing what's best for your patient, people see that. And patients see that, patient families see that. And that's really all that matters. Just be a pleasant person to work with and try to do a good job and try to take care of your patients. So I think Joe and Dave really set the tone very well for that.
I would agree very strongly with that. I think to start this type of program comes back to having credibility, and you gain that credibility by demonstrating that your aspirations for building a program are not about you. They're about taking care of patients and what's best for the community and the institution. So I can see situations where people try to build a program around an operator who wants to build a practice, so to speak, where it's a more sort of self-focused initiative, and that's never been the case here. And to compliment Dr. Kanaa'N and yourself, Ankur, I think that you very much live up to the concept of patients first and doing the right thing for the patient, and that approach is very idealistic, but it has very practical implications for the credibility you get for the program. I think one reason that we have done well with the startup of this gets to the root of it, that we're doing it for the right reasons. We want to do this to make sure that people in our community get the best care, and that our institution is operating at its highest capability. And so that gets you credibility with say, for example, administration, who also have to look at the practical implications of starting a program. Is it viable? Is it going to be able to support itself? Those kinds of things. But I agree with Anmar. I think that our approach has been a patients first approach. It's not been about a particular operator. It's about a program. And we're very fortunate. I feel very fortunate to work with people that want to work together as a team. And I think, as you know, TAVR it's the ultimate team sport. Actually, it really is.
Yeah, no, I couldn't agree more. I mean, I think you need incredible input from cardiology colleagues who have a focus on imaging. You obviously need, interventionalists who are invested in the technology and the procedure, and you obviously, you certainly need input from surgery and their participation. And I truly think it's the perfect amalgamation of different skill sets, with a common goal of taking care of the patient. And as both you and Anmar know, our patients are very complex. I mean, aortic valve disease and transcatheter aortic valve program is just not only about putting a valve in. A lot goes into pre-procedure planning, post-procedure follow-up. Also, immediately post-procedure, just setting up protocols, making sure that patients are getting appropriate care, getting appropriately triaged as soon as they're done with the procedure, with expeditious discharge. Anmar, do you want to talk about the process? For listeners who are wanting to start a new program, what are some of the nuts and bolts for success? Because, you and I, and even Dr. Lahorra, we've all talked that it's not just about putting a valve in.
That's absolutely correct. I mean, the parts that I was very familiar with are the clinical parts, and that's something that Joe had alluded to. But I was not very familiar with the finances and with the other action plans that had to be put into place for a program to start. So I was lucky to have Joe to kind of push that forward, and we had our own administrators that helped with that. And we had a lot of support from main campus to get going. Once we thought we had pretty much everything in place, then we faced the CMS criteria for starting a program. And that's really what put everything on hold for longer than we had anticipated. But initially, to start, you do need an operator who is well-versed in at least interventional cardiology, preferably trained in structural heart disease and TAVR. You need at least one or two cardiac surgeons who have an interest in this and are a part of the team. You need people who are very good imaging cardiologists, and you need good clinicians, and that should go across the board. So that's from the clinical side. From the administrative side, you need people who see the vision, appreciate the need for this kind of a procedure and this kind of a technology to serve the patients. And obviously, you need somebody to be looking at the finances to see that is this program something that is sustainable, and how can we make it more sustainable, knowing that it is a necessary program. So there's a lot of ins and outs that have gone into it. And Joe and Dave Hedrick also have helped tremendously in getting a lot of these things on paper. And these are things that I was not experienced with at all. So I was very fortunate to have them to help out with that. Once everything was set in stone as a plan, the next step was, okay, what's the next step to move forward with the plan? And that's where we utilized a lot of the advice from Dr. Svensson and Dr. Kapadia at main campus. And with their guidance and with their leadership, I think ultimately we've reached the point that we're at today where we're doing these procedures. A lot along the way has really the important things that have made us start, get a good trajectory, have good outcomes, and maintain is really all the support that we've gotten and our diligence to make sure that we're doing well. And our team approach, really, I don't think I've ever seen a team approach that works as well. For us, it's easy to have a conversation, and our team meetings are just very invaluable to us to make sure that we are doing the right thing for our patients.
I couldn't agree more. I mean, I think, and Joe, compliments to you. I can say that. So I trained at Methodist, and I trained with Dr. Reardon, and he's very involved with the procedure. He is a believer of the technology, and he has, done trials at international scale to bring this technology to the forefront in order to take care of patients. And you belong into that cadre of surgeons who have embraced the technology, who don't see this as do not see this technology as competition or interventionalists as competition. And I was fortunate to do a paper with some of my colleagues from prior institutions where we looked at the changing landscape of aortic valve disease. And what we actually saw was that we were not really taking patients away from cardiac surgeons. We actually added to the pool of patients with aortic stenosis who were actually getting treated eventually, because before TAVR was existential, or TAVR became what it has now, patients with aortic stenosis who were, at least prohibitive or high risk or even intermediate risk were not actually being offered surgical aortic valve replacement. I wanted you to talk about this a little bit, because I think it's important for interventionalists who are venturing out to start a new program to actually take this into consideration very strongly, is to have buy-in from your partner surgical colleague.
I would say that the whole process of building a TAVR program, and as part of that, a valve clinic and a structural valve conference, and the collaborative approach we developed has made me a far better surgeon. So there are some practicalities to it. You talk about, I think, more patients, now that this is an option for patients, more patients are referred for evaluation of their aortic valve disease in general. It's not assumed that someone is too sick or too much of a problem to be assessed with some sort of aortic valve procedure. But I also think that it is, as I said, it has made me a better surgeon, because we look at these cases collaboratively from the standpoint of structure and function and all the various options that are available for dealing with aortic valve disease. And we make better decisions. The analogy is very much like revascularization and discussing what is the best option for achieving the best coronary revascularization in this particular situation. Although I find that the TAVR SAVR discussion to be more complex and more interesting. As Anmar mentioned, the program benefits from the input of cardiac imaging, cardiology, interventional cardiology, even electrophysiology and anesthesia and cardiac surgery. So I think it's very important. I would have to say that it's very important to not approach the initiation of the program as a competition or a separate pathway to dealing with aortic valve disease. It's the same pathway. It's a unified pathway to assessing and treating aortic valve disease. And we have to come to a decision on what is the best thing to offer the patient. I found, at a personal level, it's incredibly gratifying to me. I've never been more satisfied with my surgical practice because of the approach that we take to this.
No, that's very heartening to listen. I can vouch that you're very involved in. Also from a procedural aspect, just different steps, wire exchanges, catheter exchanges, what's happening in different steps, and at different times in the procedure, when it comes to different steps. I mean, you're very involved, and both, Anmar and I have sincerely appreciated that. Honestly, it's very heartwarming, at least for me to see that in a surgical colleague. Anmar, where do you see this? Where do you see this go? I mean, the structural heart program. I know we're still young and we're building. What is your vision for the place, and how do you see this grow?
So when we started the program, we were pretty selective about what patients to tackle and what patients to refer to our partners up north at main campus who have a lot more experience than us with it. So slowly we started doing the relatively straightforward ones just to get a couple of cases under our belt. And then after that, slowly we're starting to see a little more complex patients. We're talking about alternative access TAVRs now and hoping to move forward with that. I think in the long run, and this may be only my opinion or my vision, but in general, when I thought about just the concept of structural heart disease, I think the way it's imprinted in my mind is that the center of structural heart disease starts with transcatheter aortic valve replacement. And for some reason, I have this belief that everything piggybacks off of that if you want to expand. Because just looking at all the procedures related to structural heart disease, I think TAVR is really the new godsend. We had TPA in the era of acute MI, and then stents in the area of acute MI. And I think TAVR is up there on that scale of things that really do improve mortality. And it's a very dramatic change, and it's instantly gratifying to see. So I do think personally that TAVR is at the center and everything else kind of revolves around it. So I do see our program expanding to higher complexity patients, alternative access patients, and then from there, starting transmitrals or mitral regurgitation diseases or mitral valve diseases, and then basically just moving forward from there. Like I said, we're just very fortunate to have some of the pioneers in the field who are 30 minutes away from us just provide us with the guidance that we need. And even case to case, we do reach out to them and ask questions and ask for their advice and their input. And they're very responsive. They actually see this program as a continuation of their program.
Yes, Joe, I want you to chime in on this as well. You took over at the helm as our chairman of the Heart, Vascular, and Thoracic department. What is your vision of the structural heart program and also of the department at Akron General?
Well, I think Anmar is absolutely correct. I think that TAVR, the skill set that we develop and perfect in performing TAVR with excellent outcomes is the gateway to being able to tackle other structural heart problems as that technology develops. And we know that it's going to develop for aortic valve and for tricuspid valve and for mitral valve. Having TAVR under our belt is the way forward in that. And so as a vision, I would say that, we very much want to be able to offer patients who have valve disease all options. And have operators who know how to take care of those problems, whether it's surgical or catheter-based approach. I would emphasize what Anmar was saying about the relationships with Cleveland Clinic main campus program, which is one of the premier programs in the world. I would emphasize to programs contemplating starting TAVR is the importance of building relationship, having a relationship with an established program that's dedicated to excellent outcomes, as well as having very practical relationships with industry. These things I think are vital to getting a program off the ground. And I would commend both you and Anmar for the ongoing discussion that you have with patients as they come on board with our team up at the main campus. We are constantly learning. We are constantly improving the way we do these cases, and every case is different. So I would really stress the importance of that. From the standpoint, from a departmental standpoint, structural heart is a linchpin for maintaining a high quality cardiovascular department, and it's a synergistic thing. If TAVR is up and moving, it depends on excellent imaging, excellent CT, MR, echo, and so those staff members with those interests and skills can develop further as well. Our clinical cardiologists know that they have these options available to them. Our cardiac surgeons, as I said, I think grow by virtue of the growth of TAVR. Our vascular surgeons will be involved in this in terms of assessing serious vascular disease that might complicate the TAVR procedure. So this is truly a situation where we raise all boats, and it becomes very synergistic. I think we do not agree, Anmar, that TAVR has brought us great strides in our imaging capabilities, in our relationships with vascular surgery, with anesthesia, those sorts of things.
Yes, I couldn't agree more. I think this brings really all the service lines together, and everybody plays a role. And at the end of the day, the success of the program really depends on everybody coming together for the goodness of the patient. And I agree 100%. Our imaging capability has advanced tremendously. I think we are able to, when it comes to even hiring new cardiologists, I think once a cardiologist sets foot into the program and sees what options they have to offer their patients, I think their decision-making becomes a lot easier rather than looking at a program without an established structural heart program and having to refer those patients elsewhere. Everybody's protective of their patients because they have developed a rapport and a relationship with those patients. And the patients are very protective of their own physicians. Like I said, for us, I mean, we are a continuum of the expertise that is at main campus. And I think our team just has been designed to work together. It seems like I don't know if it was a fluke. I don't know if this was something random, but really every single person of the team has the same mindset. And I give credit to you, Joe, for setting that tone.
So Joe, closing remarks from you, and then Anmar from you. I know we're going to have a new cardiac surgeon member join us as part of the team. Maybe you want to just talk about him a little bit, and then closing remarks for the episode, and then Anmar, closing remarks from you. But Joe, I'll start with you first.
Yes, I think we're very fortunate. We have a young, newly minted cardiothoracic surgeon just finishing his training at Cornell in New York City. He is, like Anmar, a graduate of the Akron residency programs in general surgery. He has TAVR experience from his training program. So just to put things into historical perspective, when I was training, there was no such thing. I didn't have any catheter-based skills or training or exposure, and that would have been science fiction pretty much at that time. Today, the recent graduate, he's done assisted in TAVRs as a cardiac surgical fellow. So, we are blending the lines between cardiology and cardiac surgery, and I think it's a very necessary skill set for him. We're very anxious to have him on board and get him involved in TAVR, so that we have available to the TAVR team a number of surgeons, so that we're limited when TAVRs need to be done, we'll be getting them up to speed. I think too, though, that it speaks to the importance of having the TAVR program in place. We would not have been able to attract a young, recently trained, enthusiastic, and talented cardiac surgeon if TAVR was not part of if TAVR was not part of our program. And I think that we see the same thing in interventional cardiology and imaging and general cardiology as well. That if TAVR was not part of what we're doing, the young, best, and the brightest would not be interested in joining us.
No, congratulations to you for putting just an incredible group of people together, Joe. I truly feel fortunate to be part of the group. Anmar, to you, closing remarks for the episode.
So what I can say for the new graduates who are embarking on the task of trying to start a new program, starting a new program has its kind of this fear of the unknown as you move forward. So you really have to have a good group of people around you for support. There are ups, there are downs. At times, it may be apparent that this will never happen. At other times, things are moving forward. So you just really need the right support group around you who see the vision and want the success for the program. And I was lucky to have that. The other thing is, again, I cannot emphasize this enough. The program, like Joe said, is not about a person. And the team is available, whether you're looking for it or not. But it really is, at the end of the day, what tools do you have in your bag to offer your patients, to take care of your patients? And that's really what it comes down to. Everything else becomes secondary after the patient first approach. So don't ever lose sight of that and move forward with that. Do well for your patients, and slowly people will start hearing about it. And hope for great success for everybody who's trying to start a successful program.
Well, Joe and Anmar, I know it's a weekday, it's a Tuesday, and it's late in the evening. Thank you so much for your time to stay with me for that long to record this episode.
Thanks for having us, Ankur. We will see you tomorrow.
Absolutely. Thank you, Ankur. It was great. Enjoyed it.
Bye.
Bye-bye.
Dear cardiologists, we want to make this podcast about you and for you. So please email us your critical thoughts, comments and questions at podcast@radcliffe-group.com and visit uscjournal.com for more information. You can also follow us on Twitter, LinkedIn, Facebook and Instagram at Radcliffe Cardiology for daily updates. Join thousands of cardiologists and become a Radcliffean by registering to radcliffecardiology.com. You will receive regular newsletters and gain access to hundreds of expert interviews, educational webinars, clinical cases, and peer-reviewed articles from our 6 medical review journals on general cardiology, interventional cardiology, arrhythmia and electrophysiology, cardiac failure, and vascular and endovascular surgery. Thank you.